Checkmate 816. Neoadjuvant nivolumab plus chemo achieves 25% PCR, with 5-year overall survival in resectable NSCLC. Delphi 304. Tarlatamab improves OS over lurbinectedin or topotecan in relapsed SCLC, now second-line standard. Pre-3 p.m. immunotherapy increases CD8+ effector cells, boosting OS in stage 4 NSCLC. These 2025 lung cancer updates, and much more coming up now.
So the Checkmate 8116 actually was presented updated data from that trial at ASCO this year, and it was one of the, I think, the biggest, maybe most impactful study updates we had, because for the first time now we know a regimen that's already been FDA approved because of a significant improvement in EFS now showed that we have an overall survival benefit by adding nivolumab early, in the neoadjuvant setting. To kind of answer the question, how it does that is a long, complicated one. But I think one of the big things about that study is, we see that we very significantly improve the pathologic complete response rate in that population. So about a quarter of patients will have pathologic complete response after receiving neoadjuvant chemoimmunotherapy with nivolumab. And it's always dangerous to make cross-trial comparisons. So I hesitate to do so. But when we look at the PCR rates in this study, I mean they're higher than we see in some of the other perioperative studies. So the really important thing here is that we know PCR definitely improves outcomes. So in the patients who've had this pathologic complete response, the EFS benefit is much greater, and so too in exploratory analysis that was presented at ASCO this year, we see that the overall survival is also better in that population that has had a PCR. So I think, to answer the question, how does adding nivolumab early improve survival? Well, I think it's by an improved PCR rate. The other, I think, really important thing to highlight about that study and the role of nivolumab, in your combination is that study looked at platinum-based chemotherapy, so not just cisplatin. You could use carboplatin or cisplatin, and I think, as a clinician who's trying to treat patients, I think the flexibility to know that you can offer carboplatin, generally a better tolerated drug, and specifically in patients that might not be eligible or you have reservations about receiving cisplatin, and knowing that you still have great outcomes and you have an overall survival benefit with that drug, I think that also helps us.
In the Delphi 304 trial, how did tarlatamab work better than chemo for small cell lung cancer that came back?
So in Delphi 304, we had this was the big phase 3 comparison of tarlatamab, DLL3, CD3 bispecific T-cell engager versus chemotherapy. And what was great about this trial is this was the first big trial. This drug was already approved on phase 2 data, but this was the first time we were looking at it, comparing it with kind of dealer's choice chemotherapies, and we saw not only an overall survival benefit overall, but when you look at the subgroups of chemo, it beat the individual chemos. Now, it wasn't powered to do that, so again, it's always dangerous to really conclude. But whether patients had, lurbinectedin or topotecan as their second-line drug, we still saw this improvement in overall survival. So it's a very exciting, drug. I think this is now, established. It was already approved based on the earlier studies, but now it's, I think, kind of entrenched as the standard of care for second line in small cell lung cancer after progression on first-line chemoimmunotherapy.
What does the IM40 trial show about using azilizumab with lurbinectedin to keep small cell lung cancer from worsening?
IM40, very also interesting, important trial looking at maintenance lurbinectedin in addition to atezolizumab in patients who have had stable disease or better, PR or CR on first-line chemo atezolizumab therapy. So this is a really important area in small cell lung cancer. For years, the paradigm was simply induction, chemotherapy, and then waiting, essentially, for progression. Thankfully, we've learned that adding, immunotherapy into that first line and then continuing the immunotherapy as maintenance, improves survival, and so that is now the standard. But what remains is a huge unmet need here because, despite the benefits we saw with the addition of immunotherapy in first line, the majority of patients actually don't make it to second line therapy. So you look at the studies, between 50 to 60% of patients, at the time of progression, it's either a catastrophic progression or they're too unfit, or for whatever reason, they don't actually get to a second line therapy. So in this study, they were looking at basically moving, one of the approved second line therapies, lurbinectedin, an alkylating agent, into the maintenance setting. And of course, anytime we're looking at the maintenance setting, event-free survival is really not enough. We really want to understand, if we're doing that, are we really improving overall survival? And we saw, this summer at ASCO that in fact we are. We're getting significant approval in overall survival by adding lurbinectedin into the maintenance setting without I would say unexpected toxicity is the best way to say it. We do see some more cytotoxic, expected side effects, such as cytopenias. This is managed with prophylactic GCSF, so we do GCSF support on these patients receiving this, and what we didn't see was, a lot of discontinuation because of toxicity or neutropenic fever events. So I feel like it's, I feel comfortable that it's a safe regimen to add early, and with the improved overall survival, the ability to make sure people are getting an active drug, even if they're getting the opportunity to have an active drug. I think this is now, it's certainly my kind of standard of care for maintenance patients who I think can tolerate it.
Why might getting immunotherapy before 3 p.m. improve survival in advanced stage 4 lung cancer patients?
So this is my favorite study presented at ASCO in the lung cancer space. Just a really profound benefit we saw in terms of overall survival in patients receiving their chemoimmunotherapy early in the day before 3 p.m. versus patients who are receiving it after. And it just opened up a world, I think, of questions for all of us. And the curves are they kind of split so dramatically early and continue to grow with time that I think it's hard for us to ignore. So to answer the question of, why, so it's clear there's something there. To answer the question of why, giving it early, I think there's still a lot of investigation that needs to occur. But we do know some, and there was some great correlatives done on that study, and they show that actually if you're receiving, the immunotherapy early in the day, your CD8 positive effector cell counts actually increase with that dosing, whereas if you're receiving it later in the day, you actually see decreases over time. And similarly, your CD4 positives increase if you're receiving it late in the day. And so the ratio of your effector versus your immunosuppressive cells actually increases very significantly in the patients that are receiving immunotherapy early in the day relative to those that are receiving it later in the day. And similarly, we saw when we look at active versus exhausted, T cells, same thing that we see in the early population, that ratio increases over time, whereas if you're in the late time of day population, that ratio gets smaller over time. So there's clearly something immunologic, whether that's the cortisol levels that we have in the morning and how circadian rhythms impact immunology. I know somebody smarter than me can help me understand that too, but there's definitely something there that needs to be explored. And I think the other thing that I just kind of think about here that's funny and makes you scratch your head is I want to look back at all the other studies we've done historically. I do a lot of early drug development. I'm a phase 1 clinician, and one of the things that sometimes people talk about is how we have all these very promising therapies, in phase 1 that don't always necessarily pan out when we get into our phase 2s and 3s, and it just makes you wonder. The data from this study, are some of our benefits just because we're treating people so early in the morning on phase 1 studies? Our phase 1 studies, we have very long days. Patients have to come for 8-hour, 12-hour PK assessments, and so we start people really early. They're all receiving their treatments early in the day so they can stay around for long observation periods. May they not have looked as promising had we treated them later in the days? It makes you wonder.